So welcome to the Demography Colloquium today. Just a reminder, please don't forget to sign up. The sheet or just mark that you're here in the event of needing contact tracing. It's a great pleasure for me to introduce to you today Rogelio Sáenz. Rogelio is currently professor in the Department of Demography and Sociology at the University of Texas, San Antonio. He was Dean of the College of Public Policy, UTSA, and he holds the Mark G. Udoff Endowed Chair at the University of Texas at San Antonio. Prior to joining UTSA, Rogelio was professor of sociology and department head at the Department of Sociology of Texas A&M University. Rogelio is also a senior fellow at the Kersey School of Public Policy at the University of New Hampshire, and I don't quite understand how that works, but Rogelio's research is on Latinos, Latinas, Hispanics in the United States, issues of race relations, inequality and poverty, immigration and migration, public policy, social justice and human rights. He is co-author of Latinos in the United States, Diversity and Change, that I use in my class. He is co-editor of the International Handbook of the Demography of Race and Ethnicity, and co-editor with Javidan Rodriguez and Cecilia Menjivar of Latinos in the United States, Changing the Face of America. Among his many recognitions is the 2018 Cesar Estrada Chavez Award from the American Association for Access, Equity and Diversity, and the 2003 Research Teaching Award from the American Association for Hispanics in Higher Education. Recently, Rogelio has been producing very interesting op-ed pieces related to Latinos and COVID that have appeared in venues such as the Austin American Statesman, El Paso Times, the New York Times, San Antonio Express News, and many others. So it's a great pleasure to have him share his research on COVID and Latinos with us today. So please help me welcome.
Thank you very much, Emilio, for the introduction, and I really appreciate getting the invitation to come to your center to talk about the research that I'm doing. And so what I'll talk about is kind of the last more than month and a half, not month and a half, year and a half that I've been doing work on the COVID. Tell you a little bit about the background, how I got started with that, and so forth. So the outline, I'll talk a little bit about my own personal and academic background, as well as introductory remarks, how I got started on the Latino COVID-19 research, a little bit of the theoretical grounding, and then the data sources, and then I'll spend more time on the early findings that we were seeing, and then the ongoing and latest trends, because as the title indicates, the subtitle is The Evolving Story, because as we know, this is a story that continues to take very interesting kind of turns, and you see interesting trends, and then I'll go on to the ongoing and latest trends, and then the closing words. My own personal background, I grew up in the South Texas area, as far down as you could go in Texas before getting to Mexico. Grew up in that area that was very much a bicultural, bilingual area. And it is part of the story is also the devastation that took place in this particular area, South Texas, and much of the border that took place probably there in June, July, August, into early September, where it was kind of a miniature version of what we were seeing in New York City early on. The devastation that was occurring, bodies that were piling up, and whole families also being impacted very heavily. And my own work has always had kind of an applied bent to it, public policy related. What the scholars talk about public sociology or public demography, trying to bring in these issues of the social sciences, sociology and demography to address major issues that are taking place in our society. My research is in line with what was about to take place during this, that would change our lives. And it started early on as we were all locked up in our own homes or wherever we were and trying to figure out what was going on. And early on, it became painfully obvious that the COVID was having a disproportionate impact on people of color. We're seeing, thankfully, we're seeing the New York Times, Washington Post, The Guardian was producing excellent work that was providing us the images as well as interviews that were going on, telling us the story that was taking place. And at that time, there was some work that was coming out that was being published in, particularly The Guardian was doing an excellent job of keeping up with what was going on. But it was about how African Americans, for example, they were comparing data on their percentage representation in the states and in communities such as Milwaukee, such as Chicago, New York, and so forth. And it was clear that African Americans were totally disproportionately represented among people who were contracting the virus and who were dying from it. And at that time, there was relatively little. I was going and trying to find information on the Latino population, and there was very little. And I ran across, and this would have been late March, early April, and I ran into a link from Black Lives Matter that had a link to each of the state portals, and it identified those places that race data were being collected. So I had gone into that, and at that time, early on, there were about 6 states that had information on the Latino population. The Latino population has always been very difficult in some respects because oftentimes they won't separate whites, non-Hispanic whites from Latino whites, etc. So it was a bit difficult, but there were about 6 states, and then there were some cities, for example, San Francisco was reporting data on the number of cases. And there it was very obvious that Latinos, and there you have particularly an immigrant community that had been devastated with catching the virus. There was data on New York City, and Milwaukee, I think, was another one. And I would go periodically and collect more information. And it was a bit difficult because everything was happening so fast. There was, of course, no standardization that was taking place. And then fortunately, by the time we're talking about early May, there was the next slide here. No, I don't have, yeah. The COVID racial data tracker, which was very, very important. And that had provided you wide information because it provided you information on the virus, the cases, as well as the deaths. And then later on, it would be the CDC, then that released weekly data. It became much more easy. And then I was trying to get the information out as quickly as possible because there were all these questions about what was going on with the Latino community. So I was trying to say, how am I going to do this? And then I had a little inspiration, and I remember Latino Decisions, which is a major, Matt Barreto and others, political scientists, and they have ongoing surveys on the Latino population. And then they said, no, we have a blog series. You can do the blog. And then so I was doing a monthly blog, what was going on in the Latino community. And then other outlets, for example, the Latino Rebels is an online news area that I've published there quite a bit. And then Pointer in Tampa, I believe they're a national organization of journalism. And then they had gotten some funds to put together a series on how COVID was affecting people of color. So they asked me to do one about the time then that the bodies were piling up in the valley area that I had mentioned, and then a follow-up, and then of course locally with San Antonio News, and then the Dallas Morning, and they have been continually looking at these particular trends that I'll report. And the kind of the theoretical grounding is very much systemic racism as the major culprit in terms of what was going on. And we saw this systemic racism very much part and parcel of the story of the founding of the United States. And then we've seen the extent to which there has been much denial about the white supremacy and systemic racism. But then, interesting, it was like as we well know, it's like this movie that we're seeing, that it's the pandemic, the murder of George Floyd, the demonstrations afterwards, and you see greater parts of the community that have been in denial, that all of a sudden they say this is something that is real, that we can no longer deny. But you see it, I think, with the confluence of racial inequalities that we see, the significantly higher infection rates, especially early on with people of color compared to the white population, people of color being disproportionately in essential jobs, in meatpacking, if you remember back in May, meatpacking places were being disproportionately hit in the grocery stores, the distribution of food, agriculture, etc. The loss of jobs and the lack of job recovery very early on when this country lost, there were about 25 million fewer workers in April. These were disproportionately people of color and disproportionately women. And then the lack of medical insurance, particularly among the Latino population. The Latino population historically has had anywhere from 30 to higher percent of the population that are not, they do not have healthcare insurance, and particularly with the immigrant community, the crowded living conditions as well as the multi-generational households that made it easy for people being on the front line and then coming home and not having that luxury of being able to have your own particular bathroom or your own bedroom and so forth, that made it easier to spread. And then the unauthorized immigrants, in many ways, left at their own devices to fend for themselves when they were excluded from receiving the $1,000 check, for example, and even their spouses, if they were citizens but they were married to an unauthorized immigrant, they did not have access to those funds. So these inequalities did not just crop up, but rather they're part of that story that created and made people of color, as well as the poor in general, vulnerable to this pandemic. And Sabrina Strings wrote a very interesting and important piece in the New York Times in the summer of 2020, where she illustrates with the concept of what she calls bare necessities for blacks and other people of color, extending back to slavery and the extent to which public policy had continued to provide only the bare necessities. And my own state of Texas represents the major kind of minimalist approach to healthcare, to the safety net, and so forth, as you can see from the kinds of policies that are being passed in the state the last several months. And again, the data sources that I've been using, the first of these COVID racial data tracker is no longer available. It's a lot of work trying to, every week that they have to do. Now for the CDC health disparities, and the interesting thing here is that you have data, one set of data has information at the state level, so you can see states, and every week they release the data. Part of the problems, especially for the younger age categories, is that if there is between 1 and 9 deaths in that category, the number is suppressed, so you don't have the ability to be able to calculate death rates and things like that. But it's still some of the richest data that we have. So I'll talk about the early findings, and this was early on, and we're talking about April and May into probably about August, September of 2020. And there were two stories that were emerging with the Latino cases and the Latino deaths due to COVID. So early on, I had the data, and you can see that on the left-hand side, at the top, I have the states where Latinos were overrepresented among those people who had contracted the virus, and then at the bottom, then states where Latinos were overrepresented among people who are dying from COVID. So early on, the May data, for example, was showing that 29 of the 35 states that had information on COVID Latino cases, Latinos were disproportionately overrepresented, and that became even more obvious in the coming months. The state of New Mexico was the only one that that was above that 45 out of 46. It was New Mexico. Part of that was indeed some of the very aggressive steps that the governor took to try to protect the population. But another more unfortunate situation was that the Navajo Nation was being disproportionately hit, and they were the ones that were disproportionately among people who are dying from COVID. And then at the bottom here, you can see that Latinos in the first one, there was only one state out of 29, and that was the state of New York. Then 6, and then the height we're seeing those big surges that were taking place during the summer of 2020. In August, there were 21 out of 46. By the time we're talking about February 2021, 6 out of 48. And here, this is just Demography 101 in terms of the age structure. So if we compare, for example, Latinos to the white population, we can see the age structure very different. Median age, Latinos 30 versus 44 for whites. With children, almost a third of Latinos are children less than 18, compared to the white population, 19%. And then the group that was extremely vulnerable to COVID, you can see with the Latino population, about 1 out of every 14 Latinos are 65 and older, compared to about 1 out of every 5 whites. And you can see the age-sex pyramids very clearly that show the difference. And so early on, the data that were available that allowed for age-specific death rates were for California, for Utah, and then New York City. And then once I went into those areas and then put in the age-adjusted mortality rates, then you found that Latinos were actually, and African Americans were dying disproportionately much higher rates than the white population. So by September 2020, for example, we were seeing that once you took into account age differences and calculated age-adjusted death rates, blacks were dying at rates 3.44 times higher than whites, Latinos 3.11, Native Americans 2.5, and even Asians that traditionally had much lower death rates compared to the white population were dying at rates that were 45% higher than the white population. So that was early on. And then another trend that was coming out was the COVID and the Latino paradox. And we know that for the Latino paradox, it's been now 2-3 decades where there's been support for the paradox, with Latinos having death rates that are significantly lower than whites and a higher life expectancy. And early on, we, with Mark Garcia, who's now at Syracuse University, we did for the Journals of Gerontology, the disproportionate impact of COVID-19 on older Latino mortality. And at this time, we're talking about the rapidly diminishing Latino paradox. And overall, if you look at the earlier years, on average, Latinos had death rates that were about 29% lower. And the question is whether the paradox held. And these are data for the COVID death rates. And you can see there the older category, 55, 64, 65, 74, 75, 84, and 85 and older. And we can see that if we take a look at whites, blacks, and Latinos and blacks are disproportionately overrepresented, the highest death rates at each of these ages. And then these would have been the non-COVID deaths. And here with the non-COVID deaths, if you look at the Latino community here, it looks like here the paradox holds. Latinos have lower death rates compared to the white population at all deaths that are not COVID. And then the big question then has to do with COVID and the Latino paradox, because with the overall all causes of death, because that's what we have been using in terms of looking at the paradox. And we can see that for the most part, it's very, very little differences at 55 to 64 and at 75 to 84. And for the group 65 to 74, now Latinos for all deaths are dying at rates that are higher than the white population, less so at the 85 and older population. Now, keeping track of these particular death rates and across whites and blacks, for example, the ratios, we can see, and again, those 4 age categories. And the data that I just presented were data that were the cumulative data up to August 30th. I always put 2000 instead of 2020. Yeah, that's supposed to be 2020. And then you can see at further points in time, and here's again the evolving story. We can see that at the end of January 2021, for the 55 and to 64 age category, if you take total deaths, we can see that Latinos were now dying at rates that were higher, and that lasted until the end of May, and then all of a sudden, then the last 4 time periods, it's been slightly below. It's been pretty consistent for the 65 to 74, as you can see in red there. All of those Latinos have higher mortality rates due to COVID. And then the 75 to 84, it looked like it was going to take hold early on, but it hasn't materialized. And for the 85 and older, it's much more, has been pretty stable in the kinds of findings we would find before the pandemic. And some of the factors that accounting for these shifts that we've seen have been the early on, you have in terms of the temporal, we saw that it was people of color that were hit hard very early on, and then more recent white surges have been associated with some of the opposition to vaccinations that we've seen, particularly in red states. And then also we've seen that Latinos that have gotten vaccinated vaccinated in those places where they've been very hard hit. In Texas, the border region, for example, had some of the highest death rates and so forth. And it is the border region of Texas, for example, where you tend to find the highest levels of vaccination rates. And then there's a possible, perhaps, the birth cohort differences with the younger cohorts at the older ages and those that are older. And then this is the latest data that again, January 1st, 2020 to September 25, 2021, that gives you across the age groups. And this is again the ratio of white death rates, age-specific death rates to Latino to white. And we can see that at some of the younger categories, 0 to 4 and 1 to 15 to 24, that there we tend to find higher levels. Part of this might be that with the white population in some of these states, you still have the data that are suppressed. So they may have 8 deaths, for example, and they're not counted. Whereas with Latinos, they got to the 10 threshold earlier. So that might be what's going on. And you can see that it's a 65 to 74 where you have a little bit higher right now. So it looks like at some point in time, that 65 to 74 is also going to kind of even out. And then the overall impact of COVID-19 on the overall Latino mortality. In 2019, Latinos, the age-adjusted death rates were about 29% lower than the white population. And during the period here, January 1st, 2020 to September 25th, now I put 2021, DR from all causes is now 9% lower. So you can see the difference, perhaps an indicator of the impact. Then sometime in early December, a journalist from the Dallas Morning News had contacted me that she was doing a story on the impact of COVID on people of color. And she asked me a question, a very interesting question, and that was, how many years of life have been lost in Texas? So I put together an analysis using life table data and then the number of people at different age groups that had died and the potential years of life they had left. And we're finding that at that time, we're talking about up to early to mid-December, there were about 405,000 person years that had been lost in the state of Texas. And because Latinos were being disproportionately hit, it was the largest number of deaths among all racial and ethnic groups. It was also the highest, and also because of the life expectancy is higher. On average, Latinos were losing about 20.2 years of life compared to other groups, and they accounted for about, 60% of all the person years that had been lost at that time. And then there was the milestone of misery, and that is in early April, then it was where Latinos surpassed the 100,000 deaths at that time. So I had written a piece for Latino Rebels, calling attention to this, and now what we see is that right now, almost closing in at the 125,000 area. And then we have the ongoing and the latest trends. Some of the and what we've seen, remember that we have the 3.4 or so gap, and we're seeing now the declining gap here, but still major differences. So you can see with the black population, and black population here in particular, went from 3.44 that you saw earlier, the gap black to white, and now you can see 1.93, 1.92, still significantly different, but much less than they were earlier. So something happened. I don't know. I've been looking to see if anybody has been writing on this, but it seemed that something effective took place there. And then with the Latino population, it has gradually gone down now 2.19. The Native American, as I mentioned, have over the last 8 months or so have been the highest death rates, and here it's 2.28 times higher. And then we've seen with the Asian population also the adjustments that took place, and now Asians are dying at rates about 7% lower compared to whites. And then we see the large gaps also with the Latino population across the age groups, but they have been narrowing quite tremendously, all the way from the 15 to 24 to 55 to 64 age categories. For the 35 to 44, some of these at one time were about 6 times higher, and that now they're about 3.5 or so. Not only because they're still quite wide. And then we have the consistent and slightly changing demography of COVID fatalities. And this is very interesting, and this really shows the impact of people of color that were on the front lines and that were disproportionately dying at younger ages. With the white population here, for the most part, for most of the period, it has been about 90%, 89, 90% of whites who have died have been 65 and older. And then for the other populations have been pretty consistent. That is, for Latinos, about 61% or 65 and older, 67% for blacks, 58% for Native Americans, and Asians are somewhat closer to the white population with 78%. But in green here, you can really see the differences. This would be the 50 to 64 age category. And we can see that with whites, it's 12.5%, 16.9% for Asians. But then for the other 3 groups, we're talking about approximately a quarter or so, or 50 to 64. And then less than 50, you can see for the white population, 3%, versus for American Indians, 15%, blacks 9%, and Latinos 12%. So you can see that the demography is quite different, and to a certain extent, it reflects that the presence of people of color in the front lines. And then you also see changes in the death rates across states as well for the Latino population. And you can see early on it was New York that was had the highest rate, New York, then New Jersey, District of Columbia, etc. And then you've seen some of the changes. Texas has been 5.5 and it jumped up to 2. The District of Columbia, the Latino population is relatively small, but it had gotten hit hard, and since at least April of 2021, it's been the highest death rate, even back in December 2020. And then there have been new areas that have emerged. So, example, Arkansas, more recently among the red states that we've seen with increasing prevalence of death the last months, is one of those areas. And then the temporal trends is also very interesting, because you see, this allows you to see the waves that have taken place. And so what I do here is, for each group, for example, Latinos, blacks, whites, in this graph, I take the total deaths that have occurred during the period, and then I divide week by week what percentage of the total And then that allows you, and take into account a little bit that you can compare across groups that are very different size-wise. And you can see, particularly with Latinos and especially African Americans, early on how tall those bars are early on, and then the waves that have occurred, and then with the black population and the Latino population, the latest surges. And we can see with the white population early on, they were not as high, those bars were not as high as you found with the Latino and black population. And it has been in that period in later 2020, and then kind of the surges that we're seeing in the more recent time frames. And then for the other two groups that we have data here, the Native American population and then the Asian population, you can also see Asians. Another group that early on got tremendously hit, and if you recall the ratios that we're showing, that the ratio of Asian death to white death was 1.45, and then you see that surge again, and the uptick at the latter tail there is not as significant. And then these are the trends that we see over the period January 2021 to August 2021. So these are monthly periods comparing January death to August death. And you can see the trends that we find, particularly 18 to 29, 30 to 39, 40 to 49, 50 to 64, but particularly the first three have been with the white population and the black population at those younger ages that we've seen the surges that have been taking place, perhaps associated with some of the vaccination issues that are going on. And then once you get to the 65 to 75, 75 to 84, and 85 and older, groups that are more likely to be vaccinated, you also have the tremendous declines that we see from August from January to August. So just the closing thoughts now is we've seen then people of color, particularly Latinos, indigenous people, and blacks have been disproportionately impacted by the pandemic. And as we've seen with the work in terms of systemic racism and so forth, what we've seen before, and populations that have been put at risk and have really been devastated. And then we've also seen with a white population, some of those white COVID mortality advantages have narrowed down somewhat, and we've seen those gaps that have declined somewhat. And then we have the final line is stay tuned. As I say, this is an evolving story that is taking a lot of turns, interesting turns, and then these trends that are evolving trends that are taking place. So with that, I'll open it up.
Thank you, Rogelio. Now we're open for questions and comments. Rogelio.
Yes.
What do we think about heterogeneity in terms of reporting cause of death? So for instance, some white people might be in like Missouri where someone has said, I'm not going to report COVID as a cause of death, versus, you know, Latinos and African Americans might be in areas of the country where they're urban, they have a professional person who records these things from the CDC.
Yeah, that's been a major issue from the beginning in terms of the recording that is taking place. I don't know if there's a way to try to control for that, and if you have kind of an indicator for particular states, if you're able to determine that, or a dummy variable or a set of dummy variables. And right now, the interesting thing is eventually will be kind of the multivariate kind of analysis that we can do from these kinds of data. But that's been an issue early on, particularly I think with respect to the classification. Another has been the classification of race and ethnicity, particularly early on when, well, it continues to be the case that if people are hospitalized, they don't have relatives there with them. So there's a potential also for misclassification of race information as well. Is the other part of that story. Yeah. Needing to control. Yes, sir.
Yeah, thanks very much. Very interesting. It's very consistent, some of the work we've been doing here recently, of showing how the Hispanic mortality paradox has disappeared. That was pretty much wiped out by COVID. and that it was really true that, like you show, mortality from COVID, not from other causes of death.
Yeah.
But what we also, sort of going back to Michael's point, is that we've done some analysis on excess mortality that's not COVID related by county, and a lot of the counties where there is a lot of excess mortality are counties with minority populations and also with medical examiners that are not medical people. So once we sort of, but I haven't seen anybody do, and I don't know, Annalise, you might, when you were doing that paper with us, like projecting what's the excess mortality by race and ethnicity. We have excess mortality for the entire population by characteristics of counties, but we haven't estimated excess mortality by race and ethnicity, which is something that we probably should do actually. Because I think that the underreporting may be particularly serious. You know, there are a lot of Latinos who live in rural areas.
Yeah.
Small towns, they're not in all urban centers, and that's where the medical certification seems to be particularly problematic. So I'm interested in talking to you more this afternoon about some of the work we've done. But yes, it's very consistent.
And then the other interesting thing, Irma, is that if you also look at this, I just presented the national data, but then if you look at the states and look at the paradox, there's also very interesting trends that emerge. I think some of the interesting trends that are emerging from that kind of analysis as well is in the new destination areas as well, places like North Carolina and Georgia, that overall, that there isn't a particular of the older ages, for example, there isn't any of the age categories that are over 1.0. Part of that might be the age structure. We know that Latinos tend to be younger in the new destination areas.
The analysis we did for 2020 shows really the highest increases is below age 65. And that relates to your point of essential workers, people working in the manufacturing plants, the intergenerational households. Yeah, I think it's very important work, and I hope you continue.
Yeah, and I think that the on the other side of the coin, having to do with the children, I think that Latino children in particular have gotten to that threshold of 10 younger at an earlier stage, and now I think that as there are unfortunately more of those deaths that are taking place, given that they're not younger than 12, that they're not eligible for vaccination. That also is a range of possibilities. And then the other major thing has to do with children who have lost parents, for example. That's another major area of a study that is going to be extremely important.
Yeah, very interesting. You know, this picking up on this variation or something, is there any way to separate the foreign-born and immigrants in this story, or this is like you're talking about new destinations, that they're younger, but they are 70-80% are foreign-born new destinations. So I wonder if there's any, I haven't seen it, but I think it's possible.
Yeah, that CDC data have only for all Latinos, so it doesn't have, and then the other unfortunate thing is that for this data set that has the Latino and specific data, and for states, it doesn't report gender differences.
Oh yeah, that's what I was going to ask you about the other thing about gender, and I haven't seen I haven't seen whether there are gender differences. Also because you look at the jobs that Latinos are doing, their gender and stuff like that. So maybe are men more, but I guess in the family everything mixes. But are there gender differences, or they just no?
Kind of the work that is coming out suggests that there are gender differences, that men are dying at rates that are higher, as is the case with all causes and things like that. And that was early on, I think some of the international data that were coming out was suggesting that. But as you point out, we know that Latina women tend to be working in jobs that are much more service-oriented or being in the public and exposure. So, but unfortunately right now that data does not exist yet. Let's see. Yes.
Yes. I was curious if you could speak a little bit more about state variation, particularly how you're thinking about or whether you're seeing a relationship to those policy environments, like the minimalist responses to COVID, and what you're kind of seeing in the data there.
Yeah. So right now, I think part of the going back to the methodological kind of challenges have been in terms of the reporting, how good or how bad the reporting is. One of the things in Texas, and I had published something early on, and that was probably in about August or so, and that was that in Texas, it was coming out of the race tracker data, that if you look at the cases that we're reporting, I think in Texas, and I always preface when I'm about to say what I'm going to say, I always preface it that people are going to think that I'm exaggerating, but I'm not. It was only about 4% of cases in Texas had a race and ethnic identification. So that you were getting data on a very small slice. With mortality data early on, it was also problematic. It's gotten better, but there is some of those issues as well. But I think that with the state level data, I mean, that's beautiful kinds of analysis that can be done because you have the ACS data, that you have structural kind of characteristics, you have all the politics that are going on in the country, the red-blue divide, mask mandates, and we're putting together some of that data as well. So all of those, I think, are interesting kind of topics. Yeah. So but there's still that methodological kind of challenges that we need to find a way to deal with it. But that's the best. Yes.
You find any inconsistency with the structural racism argument, given what's happening demographically? You couldn't part of the explanation the demographic differences in where working class people are being exposed to COVID and then the response. So if you look at Mississippi, some of these states, the white infection rate is like crazy high.
Yeah.
And it's kind of like the urban places, people who are white, like stay indoors. But they, as it's spread across the country, I mean, isn't this kind of a story about poverty and interaction with? Isn't this a story about poverty mostly, about people interacting with the infectious disease who are poor?
Yeah, well, with that, I think if we were to do probably some analysis also looking at the white population, for example, that again, that you could disentangle whites with higher levels of education versus those with, that you would be able to tap more into it. To a certain extent, you do find some of those trends. For example, we've done some work on the impact of COVID on job loss. And one of the things that you find using CPS data is that if kind of the bachelor's degree or higher is kind of the key to being able to work from home. And then you see for groups that don't have a bachelor's degree, much lower. And then within there, you also see some of the race differences as well, where whites are a little bit more likely, but they're not the big gaps that you find at the college. So that may be part of the story in terms of controlling and looking at structural racism and taking into account the poverty statistics and things like that, and particularly the extent to which there are those mortality differences within or not across different educational categories or so.
It's interesting, if you look at a state like West Virginia, they got all the elderly vaccinated, but now their rates of death and it's almost all white.
Yeah.
It's sky high.
Yeah, and that's one where the governor has been on the forefront trying to get people to get vaccinated, and so very contrast to what we see in places in the deep south. Yeah. Yes.
So one of the things, I mean, this is really interesting. One of the things that we keep coming back to is the role of geography. And I know that data is not there maybe to make a within-state comparison starting at the very beginning, but I wonder, particularly looking at groups like Asians, what role New York City, like what do the data look like if you pull out New York?
Yeah.
Just because in the early crisis, so much of it was centered in New York, and so many Latinos and Asians and in particular are in New York.
Yeah, and that's part with the data that I present here. I have the overall state to kind of give the connectivity with the other states, but you do have the ability to be able to disaggregate and take it into account. And in particular, I think that temporal chart that we saw African Americans and, Latinos, and then the Asian population was the other one that you saw a big spike there early on. And that, I think that's probably a big play that is going on with respect to the New York City, New Jersey kind of effect. Yeah. Okay. Yes.
So I know that COVID has sort of been ripping through lots of like carceral facilities, and I know that South Texas was particularly stricken by COVID. And I was wondering if there is a possible way to disaggregate the data to like show, for example, cases at Border Patrol facilities or prisons located sort of along that geographic area.
Yeah.
That would be really interesting.
There is some data that criminal justice people have been using, looking at particularly the infections in jails and prison. I haven't seen that much that has been written on the detention centers, because that's another of the major detention centers and the potential for spread, and there was a spread, but there hasn't, at least that I haven't seen, that has been documented as much. But that represents another of those major areas. And I think that particularly in the border communities, the Texas border communities, where you find high proportions of the population are working in the detention centers and Border Patrol, Homeland Security, etc., and just in jails and prisons as a whole, and then the extent to which it had the impact there, as well as in bringing it back to the homes in which they live as well. And I think that to a certain extent, and there's going to be projects that are going to be going on, but that will be the important kind of work in terms of the qualitative and interviews on these workers in these particular areas and their experiences, and then in their homes and so forth. Yeah. Yes.
Yeah, I have a follow-up question regarding your response to Annalise's earlier question, where you said that only 4% of the data from Texas has any kind of classification by race or ethnicity.
Right.
And I'm curious to what extent that can be a deliberate strategy to minimize the racial differences. Do you have
Not in Texas.
Was that?
Not in Texas.
Do you have information about where the greatest gaps are, state by state, in terms of reporting race or ethnicity?
What you saw is that Texas, and then I got curious and then went to the other states. Other states, it was like 80% of the cases or so, upwards of 80%. Some of the states that had the lowest rates were at about 80% compared to 4% for Texas. So there was a big gap. And most of the states were reporting kind of complete data. And again, I don't know the extent to which that's still the case, because we know that was early on, and that was at the time that the COVID racial tracker was keeping that information, and you can go to that. But I haven't found the latest kind of data. But Texas really stood out. And if you recall, the other state that also had problems, you wouldn't see it with that reporting, but it was just in the documentation, and that was Florida. If you recall on NPR, the interview with a person who was an epidemiologist, I think that she was in charge of the data and the portal, and then she has indicated that she was being pressured into kind of playing around with the data or so, and then she resigned, and that got a lot of attention, but that's another of those situations. I don't recall Florida necessarily being at the same rate as Texas, but that's another part of the dynamics that could be going on as well. Yeah.
But how much do you think that affects the results that we're seeing with racial classification at least? What impact do you think it has?
That's a good question. I think that there's probably some, but I think that given all the challenges that we have and so forth, that in broad kind of trends, I think that that what we're seeing is fairly reflective of what is going on. I think that, again, if we go to the younger age categories where still the data are being suppressed and things like that, aside from the reporting and so forth that is taking place, that there you have the problematic ones where you have the younger ages where the numbers are still so small. And then when, like I was showing with the paradox, that you can see that those younger ages, but it's possibly going on because of this. And one of the things that I'll have to do is to look into that, is look at the states that are no longer suppressed in the younger age categories and see what those look like, to see if those differences exist or not. I'll have to keep that in my head. Yes.
A follow-up question on that. So the early data that the states were reporting were just on their websites, right? And now most of the data come from death certificates.
Mm-hmm.
And the death certificate, the reporting for the death certificate is, that's my question to you. Is the death certificate also lacking the race data, or was it just that states were reporting deaths in the hospitals, putting them on their websites, and then when they fill out the death certificate, that data should be better reported? And most of the data that you're using now, and we're all using now, comes from the death certificate. Mm-hmm. Now, death certificate reporting and for Native Americans is probably not very good, mm-hmm. and it's not very consistent with the denominator to calculate death rate. But for Hispanics, it should be better. But that's the question: is the deaths, did those early deaths on the death certificate lack the race data? Mm-hmm. That may be something we should check with the National Center for Health Statistics. But there are two different reporting systems, right? The early reporting was just on the website, and now it's official statistics that are coming out. But one thing that you may want to is that some states are slow reporting deaths to the National Center for Health Statistics. So some of the analysis we've done, we don't even use the data from the last 3 months because they're going to be reporting data for 6 months. And so what you see in the decline in the racial disparity might be just lack of reporting. Mm-hmm. Because North Carolina is slow at reporting, and some of the other states that have large Hispanic population, and especially maybe the new states, are slow in reporting the death data to National Center for Health Statistics. So you might find that when the data becomes better, that what looks like a decline is not as big as it.
Yeah, and where that was a lesson learned was in that cumulative data, that you have the big file that has data at the region level as well. And then that particular file has all the way from January, the first week, all the way to, and then I had done some work and looked at the percentage and the number of cases or of death this week, and then I got the data for the following week, and there was a tremendous difference.
Yeah, so I think that what looks like a decline might not be real.
Yeah, and then once you go past and then months or go, then it becomes much more stable.
It's about 3 or 4 months lag, I think, for most of the states.
Yeah. Mm-hmm. Yes.
So thinking about what causes racial disparities, so in addition to differential exposure, these frontline jobs that you talked about, one explanation that has been floating around is the issue of comorbidities.
Mm-hmm.
Can you say a little bit about that? Is it too small a factor to play a big role? Or?
I think it's a major factor. I think that comorbidity, and we see it again disproportionately. So there's this constellation of factors where you have people of color and disproportionately on the front lines, disproportionately also among people who have comorbidities, diabetes, obesity, all these factors that place people at higher risk. And I think that even now we're seeing the importance of comorbidities with the breakthrough cases, that it seems that people who have gotten infected, that it is people who are more likely to be older individuals as well as people with comorbidities, with serious issues, that are the ones that are more likely to have more serious kind of cases or the deaths that take place. So that is one of those, and again it's tangled up with all these other factors that come on. I don't know the extent to which there would be the possibility of kind of an indicator of vulnerability or something like that. Well, I think the CDC has some of that information at the census tract and community level, but that might be another way to bring in. But comorbidity is very much part of the story, and very much where you have people of color and the poor that are more likely to have those kind of diseases that put them at greater risk. And of course, the other one is the multiple generational households. And this in particular was coming out we're seeing back in November and December, January of 2020 to 2021 in LA, where LA, all of a sudden there were big cases. And I was reading, I think there was something in the New York Times that was coming out that that shouldn't be a surprise because of all the major cities. It seemed that the LA area was one of the highest in terms of the multiple generation households that existed. So very much part of the story that we saw in the border communities in Texas. In San Antonio as well was another of the areas that was hard hit. Houston was hard hit, and you have particularly again, really the other part of the story is the immigration as well, and the jobs and so forth. And with the immigrants, of course, early on was also the hesitancy, one, to get tested, and because of the whole anti-immigrant situation, and then the extent to which they didn't have the unemployment benefits and those kind of things as well, which is another factor that plays a role. So very, very complicated and everything very interconnected. Anyone else? Yeah,
I will ask you a final question about, we talked about this last night about, Texas and what's going on and the Latinos and the vote for Trump, lack of vaccination, stuff like that. Are these things connected? I mean, it's like when in Texas, when you talk to Latinos or stuff like that, the reasons they might not get vaccinated, are they the Fox News reason? Are they different reasons? Are they, I mean, what's going on?
Yeah, and that part of that intrigue is that it is those particular areas, and in Texas, there were 14 counties that Biden won, but Trump got anywhere from 1/3 of the vote in El Paso County to close to 50% in South Texas. And then he won 6 counties as well. One of them, Zapata County, where Hillary had beat him by 30 points earlier, percentage points. He won by 6%. But some of those counties are at the same time some of the ones that are the highest vaccinated counties in the state. And my argument there has been, in that inconsistency, has been that for them they had lost people. Again, that was kind of that part of the story. But you see, I think that the politics is a major area for people who still haven't gotten vaccinated. There's a misinformation, as you can imagine, very much so. And then the other part, I think, is the increasing evangelical segment of the Latino community as well, where it's associated with the vote for Trump, and I think with the vaccinations as well. Yeah. So
interesting. There's a lot to explain there. Okay. Thank you, Rogelio, very much.